Before that, we will basically deliberate on the errors made in the management of the diabetes, and for this I am inviting Dr. J.K. Sharma sir for his deliberation. He is the Medical Director, Central Diabetes Center, New Delhi, visiting professor in Faculty Department of Medicine and Diabetology, Diurnal Medical College, CID Academy of Higher Education Research, Belgavi, Karnataka. Honorary Professor, IIM Headquarters, Perfect BSc by SNBU Medical Education University, Uttarakhand, MRCP UK, Cases Examiner, International Advisor, Royal College of Physicians of Edinburgh for North and Central India, Fellow American College of Endocrinology, Fellow all 4 Royal Colleges of Physicians, Vice President American College of Physicians, ACP India Chapter, Chairman elect RCCI Delhi Chapter, Founder and Secretary General, Innovative Physicians Forum, Vice President Genetic Society of India, AC member RCCI National, and recipient of Lifetime Achievement Award 2018 from RCCI Rajasthan. So with these words, I invite Dr. J.K. Sharma sir for his deliberation.
Good evening to all. Thank you, chairpersons, for the kind introduction. First of all, I extend my heartfelt thanks to the people sitting over here, because as Dr. Mangeshkar said, Sunday afternoon, Sunday evening, even good number of people are sitting here. And thanks to Dr. Bansi Sabu, Dr. Manoj Chawla, Dr. S.R. Arvind, and all the team of Diabetes India Organizing Committee. Dear friends, I will not be talking about the recent advances and all these super special talks by the stalwarts in the field of endocrinology and diabetes. But I will talk to you regarding something which is of use to we all, starting from the general practitioner up to the top end endocrinologist. And there are certain things which we must always look for, because it is always said, if you cannot do good to the patient, please do not harm the patient. So my talk is common clinical errors in diabetes management. We all know that management of diabetes is a state of art. And first of all, the diagnosis should be confidently acknowledged. Clinical examination should be perfect. The choice of therapy is tailor-made. We have to decide which patient needs what, and always look for the associated comorbidities, and they should be effectively treated. Otherwise, if you look at the fallouts from diabetes, toes are shaved off, the kidneys fail, the nerves, the heart, the brain, they all wreak havoc on our body, and then the life becomes the grueling struggle. And we all know that diabetes management is not a sprint. It is a marathon. We have to keep running. We must not be too stringent in our management application right from the beginning, as it runs the risk of the patient being burnt out and not following through on their treatment in the long term. So if we want that this patient should have a HbA1c in the normal range, below 5.7, never ask for that. What we should look for that, the HbA1c, if we can keep between 6.5 and 7 in a general population, that will be good. And in elderly also, the range is different. This is regarding the diagnosis of diabetes, and we all know that the ADA's diagnostic criteria, A1C 6.5 or more, and this test should be performed in a laboratory using a method that is NGSP certified and standardized to the DCCT assay. Or fasting more than 126. Fasting is defined as no calorie intake for at least 8 hours. 2 hours plasma glucose more than 200 during an OGTT, and in a patient with classic symptoms of hyperglycemia or hyperglycemia crisis, even a random blood glucose level of more than 200 milligram is sufficient in making the diagnosis. There are dubious values. Fasting plasma glucose of 115 or random plasma glucose of 200 or fasting plasma glucose of 130 milligram and random of 180. Now they are non-diagnostic. And then in that case, we have to repeat the sample on the subsequent day. And
especially look for the hyperglycemia during the acute stresses like the acute MI, and then again we have to look for revise the diagnosis once the stress is over. We should not label the patient diabetic until the stress is over, and again we look for the what are the test results. In mild diabetes, severe diabetes, these are not the terms which should not be used by a clinician, because there are the layman terms and they are very, very dubious terms. Now, the advantages for the fasting plasma glucose assay is easily automated. It is widely available and it is inexpensive and it is single simple method. The disadvantages are the patient must be fasting for 8 hours and there is a large biological variability. Diurnal variations, sample not stable, some labs use serum instead of plasma, so all these factors should be considered before deciding. The oral glucose tolerance test, again, it is a sensitive indicator of risk of developing diabetes, early marker of impaired glucose homeostasis, and at this time we can pick up the pre-diabetic patients or look after them. Lacks reproducibility, extensive patient preparation is required, time consuming and inconvenient for patients, unpalatable, expensive also, and it is influenced by various medications, sample not stable, to be done in the morning. Now HbA1c, at the time when we were in the medical schools, the test or the parameters, the factors which we were taking care of was the urine sugar, the urine ketones, blood sugar fasting, 2 hours postprandial blood sugar, or OGTT. But now is the time when we go for HbA1c, when we go for glycemic variability, and now again is the time when we look for the time in range. So with time things are getting changed. HbA1c, no fasting is required, sample may be taken any time of the day, very little biological variability, it reflects long-term blood glucose concentration, assay standardized across instruments, and concentration predicts microvascular complications. Disadvantages are may be affected by decreased lifespan of the RBC in different conditions. Selected hemoglobinopathies may interfere and may not be available at all places, and it is costly compared to blood sugar fasting. Now the factors that affect the A1C, there is a decreased HbA1c value in pregnancy by 0.5%. Vitamin A and vitamin C consumption also decreases HbA1c. Antiretroviral drugs, chronic liver disease, ethnicity like in Asians, and hemoglobin S, D, G, C, and E, so they all have a decreased value of HbA1c. On the other side, it is increasing with age, 0.4%. When there is high triglyceride or high bilirubin, again it is increased. Renal failure, carbonated, aspirin, acetylation, increased HbF levels, and iron deficiency. So before deciding exactly what is the status of HbA1c in a particular patient, we have to look for these associated conditions. Now, sensitivity and specificity of HbA1c at various cutoff levels in NDM subjects. You can see that. Cutoff level at 6.1, the sensitivity is 81% and specificity is 81%. If the cutoff level is taken as 5.7, the sensitivity is 92, but specificity goes down. So you can see in this table that as the cutoff level increases, the sensitivity decreases and the specificity of this particular test that increases. Now there are certain errors in the diagnosis. Biological variations, there may be intra-individual, inter-individual, and day-to-day variations. Then there may be pre-analytical variations like pertain to the specimen before it is measured, and there is analytical variations like differences resulting from the measurement. So we have to look for these errors in diagnosis also. Now what are the implications? It affects the treatment choices and the risk management. It can have psychological and financial implications on the patient, and it undermines the quality of care and research. Now the biological variations in the glucose and HbA1c. Intra-individual variation in glucose in a healthy person is between 5.7 to 8.3%, and inter-individual variation is up to of 12.5%. In HbA1c, the intra-individual variation of A1c in healthy people is minimal with CV of less than 1%, and the variability between individuals is greater. The other important factors is the diurnal variations. The NHA-NES third based on the fasting plasma glucose, the prevalence of diabetes in afternoon half than that in the morning. Time to analysis, the plasma glucose decrease in the test tube by 5 to 7% per hour due to glycolysis, and the nature of the specimen plasma glucose in whole blood are 11% lower than that in the plasma capillary. This plasma glucose can be 20 to 25% higher than venous plasma glucose during an OGTT, and this is the point when our patient asks that I did in the morning, my blood sugar at home was this much with the capillary method, and when I went to the lab, the values came to this. So this should be considered, and this is the answer for that. Now the pre-analytical factors, glucose, acute increase in plasma glucose concentration in acute illnesses and major surgeries, then corticosteroids, sympathomimetic drugs, isoniazid, olanzapine, digoxide and niacin are the other medicines that affect the values. When we talk of the pre-analytical factors, glucose, acute decrease in the plasma glucose concentrations, the physiological factors in pregnancy, prolonged fasting or starvation and intense exercise. These are the physiological factors which decrease the plasma glucose concentration. In acute illnesses like sepsis, acute renal insufficiency and the adrenal insufficiency, the other drugs, the oral hypoglycemic agents, antibiotics like ciprofloxacin or gefloxacin, quinine and chloroquine, salicylates and the alcohol. Then the spurious hypoglycemia is the prolonged storage of blood sample and the leukocytosis and the leukemias. So all these factors should be considered when we decide. Then within the lab imprecision, the analytical variability is considerably less than the biological variability, which is up to 8.3%. Different calibrators and the inter-lab differences are also there. Now defining the medication errors, any preventable event that may cause or lead to inappropriate medication use of patient harm, such events may be related to the professional practice, healthcare products, procedures and systems, product labeling, packaging, nomenclature, dispensing, distribution, administration, education and monitoring. So there are very many preventable events. They can all be prevented. Now when we classify the medication errors, circumstances exist for potential errors to occur. An error occurred but did not reach the patient. It was corrected even before. Error reached the patient but did not cause the harm. Patient monitoring required to determine lack of harm. Error caused temporary harm and some intervention, and then the temporary harm with initial or prolonged hospitalization. Error resulted in permanent patient harm. Error required intervention to sustain the patient's life, and error contributed to the patient's death. So we can see here from a very trivial factor, we can go up to the death of the patient. So we have to be very, very cautious in prescribing medicine to the patient. The patient should be seen in total. The holistic approach in patient management should be there, and treatment of diabetes, management of diabetes of any patient is tailor-made. Now, some reasons errors occur. Verbal orders. In the hospital, we simply ask the sister or the junior that do this. Poor communication within the healthcare team. Poor handwriting. We doctors are famous for poor handwriting. Improper drug selection. Again, we have to look for which drug causes drug interaction. Which two drugs should not be combined. Missing the medication. Incorrect scheduling. We have personally seen with big cardiologist patient going for the follow-up, heart failure patient, that time Lasix was being given, writing Lasix was missed by the doctor somehow. And second day itself, the patient went into congestive heart failure. He was rushed to the hospital. He was intubated for 2 days, and that was the problem. And when it was analyzed why it happened, then it came to the point that Lasix was not written by the doctor by mistake. Polypharmacy, again in the elderly people, polypharmacy, and again we physicians, we clinicians do not have time to look what patient is exactly taking. Patient going to 4 doctors, multiple doctors. No doctor has the time to see what the patient is being given by the another doctor for another problem. We have seen that patients are taking vitamin D, vitamin B12 from number of doctors. So please look for the polypharmacy and drug interactions, as I have already told you. Availability of the floor stock, no second check. Whatever is available is given to the patient. Look alike, sound alike drugs. Hectic work environment and lack of computer decision support. So these are the various reasons. So we should not do that. Now, treatment and the comments. When you write X60M, write proper and complete diagnosis like type 2 diabetes, obese or non-obese, microvascular and macrovascular complications and hypertension, associated comorbidities are present or not. So the diagnosis should be complete. Now you look on the left side, tablet glimepiride 5 milligram TID. I don't think this is the right dose. Metformin 500 ml BD or glibenclamide 5 milligram BD and glimepiride 2 milligram OD. So 2 sulfonylureas being written together. The calories should be prescribed and the lifestyle management should be stressed upon by the doctor. Prescription usually silent. There is no ideal body weight written. What is the existing weight? What is the duration of diabetes? What is the type of diabetes? Associated illnesses, complications. What were the previous A1C values? How the patient is improving or deteriorating? And what is the drug history of this patient? And very important is, what is the drug allergies? We must always ask the patient that, do you have any drug allergy? And it should be documented. Now, there are certain omissions which we look. Time of medication is not written. Targets, what are the targets? Follow-up duration, when the patient has to come back. Simply write follow-up as advised. Nobody knows what advice was given. Monitoring intervals and the self-care should be demonstrated properly. A key component of reducing error in prescription is diabetes patient education. So there is lack of education. We do not have much time. May reduce slips and lapses in prescription about disease, the medication, benefits and side effects and the complications of diabetes. Now, clinical examination, if you talk of height and weight, they are not measured. BMI, calorie calculation, choice of therapy, whether the patient is obese or non-obese. Now, waistline is not measured routinely. Non-obese but centrally obese correlates with insulin resistance. And the peripheral pulses are not palpated. Carotid brew, surrogate markers of coronary artery disease, the posterior tibial, peripheral vascular disease, renal brew, renal artery stenosis, caution for use of ACE inhibitors, and especially at the present time when we talk of SGLT2 inhibitors, patient education is a must. Otherwise, patient had genital infection, especially the female patients, they led up with the gynecologist, and many of the gynecologists even do not know, I'm sorry to say, that this is because of the side effect of this particular SGLT2 inhibitor. Patient comes to you after 6 months, डॉक्टर साहब मेरी शुगर एकदम ठीक चल रही है बट एक नई प्रॉब्लम गायनी की हो गई है एंड व्हेन यू से दैट दिस इज बिकॉज ऑफ दिस ड्रग एंड व्हाई डिड यू नॉट टेल मी आई एक्सप्लेन्ड यू इन एडवांस so if that is explained to the patient properly, modestly, many things can be prevented. Foot examination, it hardly takes 2 minutes for a complete foot examination in a diabetic patient. We do not say that you go for a peripheral Doppler every time or you go for a biothiometer every time. Just put your fingers on the feet of the patient. Usually ignored callosities, the nails, pulses, arcs, major cause of mortality, and the fundus, hardly any physician is examining now. But at least once in 6 months, you should send your patient to an ophthalmologist for a complete eye examination when there is retinoscopy, tonometry, the equity of vision. So most common cause of painless blindness to be seen with the dilated people. Now what is our target? Blood glucose, HbA1c, but now the target is different. We have to look for all other comorbidities also. The fasting plasma glucose, we all know, less than 100 is good, acceptable is less than 130, postprandial less than 140 and less than 180, HbA1c less than 6.5, less than 7. Triglycerides less than 150 but up to 200 it is okay. LDL less than 70 up to 100 it is okay. And the urinary albumin less than 30 but 30 to 100 when there is microalbuminuria, then definitely we should look for. The GDM indications for tight glycemic control. GDM post-renal transplant patients, acute myocardial infarction in stroke, and all young diabetics. Now, stressful situations in diabetes, the MI, sepsis, oral hypoglycemic agents are continued. Always switch to insulin. The Digami Vandenberg et al. Consistent and predictable pleiotropic effect is there. Anti-inflammatory, vasodilatory, and no synthetase activity is there. Now, monitoring of diabetes. Fasting, intensive control, 4 to 7 point profile. Postprandial 2 hours, conveniently controlled, conventional control initially weekly, once stable, then we can go for fortnightly. HbA1c at least once in 3 months, lipids once in 3 months, microalbuminuria in the urine at least once in a year if they are normal. If they are not normal, if microalbuminuria is present, then at least once in 3 months also it should be done. Fundus, if normal, once in a year, if abnormality, as per direction of the ophthalmologist. And foot examination, complete foot examination once a year, but every time patient comes, please look at the skin of the feet, please look at the foot whether the patient has any skin changes, is there a hair loss, is there edema or any cut or anything is there, please look at that. Now the standard approach to therapy results in prolonged exposure to elevated glucose, and we can see that the diet, exercise, and then sulfonylurea combination therapy, but now it is changed. Why I am putting this slide? Because we have learned all these things. Now, as Dr. Devaskar told us that after lifestyle management, start with SGLT2 inhibitors, start with GLP, and then metformin has again come as the second line. And this has been approved by many authorities also. Now, glucotoxicity, lipotoxicity, and progressive beta cell function, combination therapy, target early euglycemia and prevent cost of complication, monotherapy to avoid side effect and cost. So, tailor-made the management of a diabetic patient, which patient needs what. Please do not do any harm to our patients. Now, if you look at that, HbA1c deteriorated to more than 9% before therapy intensification. The second agent was not added until an average of 30 months after the first HbA1c level of more than 8% was recognized. So this is basically a sin. This is highly relevant because the time spent in a hyperglycemic state is a key determinant of the risk of developing diabetic complications. Lifestyle modification, of course, advised after evaluation for dyspnea for exertion, peripheral vascular disease, and obvious foot diseases, proliferative diabetic retinopathy. We have to look for 4 kilometers in 40 minutes, 7 days a week. If not 7 days, at least 5 days a week must be there, and it should be at a stretch. Time of administration of the drugs, a carbo just before a major meal or in between the meals. Glitazones anytime before meals, metformin with or immediate after meals, regular insulin 30 minutes prior to meal, short-acting insulin analogs 5 minutes before the meals, and long-acting insulin analogs, there should be a fixed time. And the best responders to sulfonylureas when the diabetes duration is more than 5 years, but this I will not discuss in detail because now the algorithms are being changed. Now look at this at least. Glibenclamide 10 milligram optimal dose, frequency is BD 30 minutes prior to meal. Glipizide 20 milligram, then gliclazide 160 milligram, and glimepiride is 4 milligram. We have seen prescriptions of glimepiride up to 8 milligram, 4 milligram morning evening. If glimepiride does not work with 2 milligram morning evening, it is not going to work in high doses also. So please look for that. Now combination of sulfonylureas, as I already told you, glibenclamide, glimepiride should be avoided. Hyperinsulinemia, weight gain, insulin resistance, and the beta cell exhaustion will further increase. Metformin with or after meal, sustained release can be given once a day also. Glitazones, obese type 2 diabetes, better response than non-obese, improved insulin sensitivity despite weight gain, adipocyte differentiation, fat still phenomenon, and redistribution of the body fat has been observed. Acarbose and metformin combination both increase GLP-1. worsening of GI intolerance if there acarbose-induced hypoglycemia treatment with table sugar, which is important, and we should be treated with glucose. DPP-4 inhibitors, a new class of drug, now it's not new, glucose-dependent insulin secretion, decreases glucagon, beta cell neogenesis is there, should be used as an add-on to metformin, delayed use should be avoided. Why I am telling you? Because we cannot put every and other patient on SGLT2 inhibitors and the GLP-1 receptor agonist. Whatever the algorithm, whatever the these institutions say, because we are from a country where economy is also very, very important. So look for that. If there are two sulfonylureas available and if there are no major changes, go for a cheaper one. Now look at this patient, 45-year male, type 2 diabetes, obese, duration of 8 years, on tablet gliclazide, metformin and pioglitazone. This patient is obese. Now we know what about pioglitazone, water retention, weight gain. So addition of two sensitizers to different class is reasonable. First try full doses of metformin and later add glitazones or half of the doses of both to begin with. Sign of evoluting beta cell exhaustion has to look for. Early insulin therapy is always advantageous because there is beta cell preservation, smooth and stable glycemic control, there is less of glycemic variability, there is increased time in range, weight gain and hypoglycemia events are lesser if insulin is used properly, restoration of beta cell glucose axis. Insulin, do not mix two different type of insulin, in that case use premix. Do not share syringes, use strength U40 or U100, use needles, once needle in tip bands, hooks or brags, fill syringe with hand, and now pens are available and we are using the pens also. Sulfonylurea with regular insulin, very dangerous combination. Patient may go into hypoglycemia, but they are given pre-meal along acting insulin in old age or renal failure patients. Definitely patient will go into hypoglycemia. So please keep a watch on the dose of the patient. Detimir and glargine are the clear insulins. Nil orally administration of insulin in certain conditions and sliding scale episode of hypos there, and sliding scale insulin therapy has nowhere been mentioned in any of the textbooks or in any journals, so please do not use that. Insulin analogs to be used, selective subset of patients, short-acting analogs or school-going children, busy executives, RT feed, long-acting analogs, elderly, ICU setting and brittle diabetes. Now I will not talk about the pumps because Dr. Manoj Chawla is here to talk about the pumps. Now these are the various injection sites in diabetic patients. Lipids and type 2 diabetes. Targets are not defined. Lipid Association of India says lower the better. You can go up to 30. The other associations, they say that up to 50 it is all right, but it is okay if you bring it down to 70. TG 150, SDL more than 45. Please do not treat triglyceride up to a level of 250 or 300 in a patient of diabetes when the diabetes is not under control. First start the statins, increase the dose of statins to the level it is required and tolerable by the patient, and then again look for the triglycerides whether they have really come down or not. Now BP is not monitored, BP in sitting position. At least once patient comes to us, we should check the blood pressure lying down, supine and standing, and at least once in both the limbs. Now non-specific selection of antihypertensives. This is again control of BP in type 2 diabetes, polytherapy, Normont NCMAC. So this is in itself a different topic. Self-monitoring of blood glucose in type 2 diabetes, on OHAs, on insulin 4 times per week. Now others, superfluous errors like clinical trials may be biased. They are randomized clinical trials. We should go for real world evidences also. Diabetic experts and drug industry tries. Sorry to say, medications frequently influenced by pharma, affordability factors and compliance, role of chemists and drug distributors is there, alternative drugs claiming to be curing diabetes and the media hype. So these are the other superfluous errors. So, and you have seen this, US cracks down on Ayurvedic homeopathic diabetes remedies. Now key message is insulin and other anti-diabetic agents are a significant cause of hospital admissions. Medication errors involving insulin are responsible for a disproportionate number of serious adverse events. Several common errors are known to occur in the prescribing of anti-diabetic medications. Education and training may prevent some errors, and with that, I thank you all. Thank you very much.
Hello. Thank you, sir. Thank you. It was back to basics, but back to basics with a stalwart. And I'll ask my co-chairperson to for the further
I would
proceedings.
like to invite Dr. Supratik Bhattacharya sir for the next lecture. He is the director of SKN Diabetes and Endocrine Center, Kolkata. He is a consultant Department of Endocrinology and AMRS and Apollo Sugar, Kolkata. He has a 30 plus international and national publications. He is the author of 5 papers. He has a lot of special achievements and awards. Over to you, sir.
So, a warm welcome to all of you, and thank you, TI, Dr. Manoj Chawla, Dr. Bansi Sahu, and the entire team of Diabetes India 2022. And thank you, chairpersons, for the kind words of introduction. So, this is going to be my topic: glucose control today and protecting tomorrow. Your patients deserve all. And as you can see up there, that's my disclaimer. I have been contacted by AstraZeneca for this particular talk. So we know that the global prevalence of diabetes is on the rise, and by the time we come to 2045, the number is going up to 700 million, and Southeast Asia is a big concern because the number is going to go up by almost 74%. If you look at India, it's already number 2 next to China, and by the time it's 2045, we're probably going to be the global capital. Diabetes management change has been there in the focus, in moving away from the glucocentric to a more organ protection or organist-centric. And obviously, we have heard from the previous talks that there is a lot of cross talk between the heart and the kidney, and this is the newest mechanism that has been proposed.
So one is the direct reductions in the oxidative stress, fibrosis, local inflammation, tubular senescence, etc. But at the same time, SGLT2 inhibitors can also cause natriuresis, which lowers the blood pressure to a modest amount, and also it ameliorates the volume overload, and in turn, this would result in intraglomerular pressure reduction. On the other hand, SGLT2 inhibitors also cause glycemic control and also caloric reduction because you're peeing out glucose from the body, and because of that you have weight loss. Together, they probably have a renal and cardioprotective effect. So the glycemic, these are the slides that has been taken from Ralph DiFronzo. So this is the, if you're looking at the renal threshold, normally it's around 180. By the time somebody has got diabetes, it is pushed to around 220. Now look at what happens when you have dapagliflozin on board. So a person with type 2 diabetes and being treated with dapagliflozin, the renal threshold is pushed down all the way to 40. So a lot of glucose is peed out, and we know that hypoglycemia can never occur because no matter how much glycosuria you have, that sends a signal which is mediated by the renal nerves, and this goes to the liver, which produces exactly the same amount of glucose that is lost in the urine. So the conclusion is SGLT2 inhibitors are not only now a diabetic doctor's molecule, but it's also being used very efficiently by our nephrologist as well as cardiologist colleagues. Again, this is a slide from Ralph DiFronzo, and as you can see in here, if you look at the ominous octet for diabetic nephropathy, you have various mechanisms like the hypoxia, hypertension, deranged tubuloglomerular feedback, podocyte dropout, for example, obesity, lipotoxicity. All of these pathophysiology is being addressed by the SGLT2 inhibitors. If you're looking at the pharmacodynamics, this is in a nutshell. So the total glucose loss by a SGLT2 inhibitor is close to 70 to 80 grams. Max HbA1c drop is almost 1%. However, I'm going to show you evidence. If you're starting with a very high baseline, you can have a bigger drop in the HbA1c. There's also osmotic diuresis. Calorie loss is equivalent to almost 300 kilocalories a day. Weight loss is about 2 to 4 kilos, depending on where you start from. The blood pressure reduction is to the tune of about 4 to 6 millimeter mercury, and also increased uric acid. Add-on therapy with dapagliflozin resulted, and this is the result coming in, versus the placebo, you can get a drop of HbA1c, which is almost up to 2%, depending on where you start from. Also, if you look at the pleiotropic benefits, body weight reduction, as we were talking about, can go up as much as 3.5 kilos, again, depending on the baseline. This is a recent study and an Indian study which shows that if you're using dapagliflozin, it improves the body fat patterning and hepatic and pancreatic fat in patients with type 2 diabetes. And it's only after a treatment of 120 days do you get to see that the mean liver fat decreases and mean pancreatic fat fraction also decreases with the use of dapagliflozin. While glucose control is fundamental to the management of diabetes, it does not necessarily translate into reduced heart failure events, and this comes from the various landmark trials. So we know that UKPDS, Accord, Advance, whatever targeted only the blood sugar parameters or HbA1c did not translate into cardiovascular benefit. So optimal risk factor management does not eliminate the risk of diabetic nephropathy, and in spite of using the optimal standard of care, you still have a residual risk that remains. So the burden of cardiorenal disease in type 2 diabetes, and we know that there are some common factors which can affect people with diabetes, both on the heart and the kidney, and this could be the altered energetics, it could be the hypervolemia, inflammation, ischemia, sodium retention, neurohormonal activation, or RAS activation. So again, as we were saying, there's a lot of crosstalk in diabetic patients. You have increased amount of heart failure and CKD. Similarly, there's a crosstalk between the heart and the kidney, and anyone with heart failure can have a worsened outcome when it comes to the kidneys. Similarly, anyone with CKD will have a worsening of the heart failure. So cardiorenal disease is the most frequent and first comorbidity that is observed with the type 2 diabetic patients. So almost 36% with CKD and 24% with heart failure. Prevalence and identification of CKD, and we know that in spite of having so many good molecules on board, the prevalence of CKD in patients with type 2 diabetes has been very consistent over time. Cardiac functions can be compromised very early in type 2 diabetic patients, and this comes from the left ventricular function in asymptomatic patients with type 2 diabetes. And there can be two mechanistic parts, one mediated by atherosclerosis, and the other one is completely atherosclerosis independent, and both can lead on to heart failure in type 2 diabetic patients. Now, if you look at the heart failure from prevention to treatment, we know that there is a long window. So dapagliflozin or other SGLT2 inhibitors can work all the way in those patients who have the risk factors but not an established heart failure. At the same time, it works well in those who had an event. So the DECLARE-TIMI was done in patients who had the risk factors, and also if you look at those with established heart failure, we have the DAPA-HF trial. So cardiovascular death and hospitalization to heart failure composite, you see a benefit while using a SGLT2 inhibitor, irrespective of the presence or absence of atherosclerotic cardiovascular disease. Similarly, SGLT2 inhibitors have shown to prevent the occurrence of hospitalization to heart failure, even in type 2 diabetic patients without established cardiovascular disease. So this is consistent both in the DECLARE-TIMI as well as the CANVAS program. So let's look at the prevention of the cardiorenal outcomes and prevention of kidney disease in particular. So DECLARE, it was different. How? Because it enrolled patients early in the disease continuum, including those without atherosclerotic cardiovascular disease and with predominantly preserved renal function. So if you're comparing DECLARE to CANVAS and EMPERAGE, you see the eGFR was higher, the mean eGFR was higher as compared to the population that was recruited for Canvas and Emperage. Similarly, if you look at the urine ACR, it was better in the Declare trial as compared to Canvas and Emperage. So Declare showed that DAPA slowed the renal disease progression in spite of starting off with a higher EGFR, and the risk reduction was to the tune of 47%. DAPA had favorable effect on the albuminuria across baseline, all urinary ACR categories, including patients with normal albumin excretion. So whether you're talking about reversal of the stages, micro to normal albuminuria, or macro to micro, you see benefits versus placebo. Similarly, worsening of the microalbuminuria stages were less versus placebo with the use of dapagliflozin. Prevention of hospitalization for heart failure, again, as I want to mark, see blue denotes those patients who had all the risk factors but did not have established atherosclerotic cardiovascular disease, and this population was higher in the Declare TIMI trial as compared to, say, for example, Emperage trial, which recruited more than 99% with an established event. So this broad cardiovascular risk population, DAPA demonstrated significant reduction in the composite of hospitalization due to heart failure, cardiovascular death, and fewer MACE events. So composite, you see the risk reduction, hazard ratio was 0.83, meaning 17% risk reduction. And MACE, although it was not significant, there were fewer numbers versus the placebo. We definitely had a benefit when using dapagliflozin in those patients with reduced ejection fraction, and this comes from the dedicated heart failure trials. But even in the Declare trial, you see clear benefits of using dapagliflozin in terms of heart failure outcomes. When it comes to the adverse events, we know that canagliflozin had concerns like, for example, fracture and also amputation. This was not seen with dapagliflozin. So if you look at Declare TIMI, DAPA-CKD, which is a dedicated renal outcome trial, or DAPA-HF trial, we do not see any triggers where there was any increased incidences of either fracture or amputation as was seen in the canagliflozin trial. So the point is, dapagliflozin can be used in the entire disease spectrum, whether you're talking primary prevention or those with established cardiovascular disease, and this is not seen with all other molecules in the same class. So we had been seeing the guidelines, and we know that anyone with established heart failure, SGLT2 inhibitors are the drugs of choice ahead of any other molecule. Similarly, anyone with established CKD, you need to consider using SGLT2 inhibitors ahead of other molecules. And obviously, if you want to minimize hypoglycemia or cause weight reduction in those who are overweight or obese, you have to have either a SGLT2 inhibitor or a GLP-1 receptor analog on board. So if you're looking at all the boxes, if you're talking about the primary heart failure outcome data, DAPA is probably riding on the most amount of data. Mortality benefits that comes from reduction in the hospitalization due to heart failure, or in using in patients with HFrEF or reduced ejection fraction, primary renal outcome data, all-cause mortality reduction in CKD, and also reduction in hospitalization due to heart failure and CKD progression. DAPA has got all the data versus the other molecules in the same class. So how to choose? Now we have generic DAPA, and why should you be sticking to the originator DAPA and not all the generics? So the reason is there is a drug development process that takes place, almost 3 to 6 years of preclinical studies, followed by clinical studies, which is almost 6 to 7 years, and then the regulatory review, which can be done at the end of 6 months or 2 years, and then the post-marketing surveillance. So this is the entire spectrum that goes on for developing an originator molecule. However, if you're talking generics, they will skip this 3 to 6 years plus 6 to 7 years of preclinical and clinical study and straight away go for an abbreviated new drug application, which is required for the FDA. And if they're happy, they approve the drug, and all you have to do is prove that it's safe, effective, and lower cost as compared to the originator molecule. So in the process, what you're doing is only sticking to the post-marketing surveillance, talking about the safety and matching the efficacy. So you're missing out on so many years of preclinical and clinical studies. So another big concern is pharmaceutical equivalence, which means stability and dissolution testing does not equate to bioequivalence, which means blood concentration of the drug in the healthy volunteers. Similarly, bioequivalence is not equivalent to therapeutic equivalence. That means what is the actual outcome in the patients. Another very interesting fact is about the stereoisomers. So spatial arrangement of an organic molecule are different than another if an atom is shifted in any three-dimensional direction by even a degree. So this opens up a variety of possibility of different molecules, each with a unique placement of atoms in three-dimensional space. And chirality means mirror image. So a mirror image is not the same as the real person. Similarly, if you have a mirror image, you can't say that this will be as effective as the other molecule, as the original molecule itself. So two enantiomers of a chiral drug may differ significantly in terms of bioavailability, rate of metabolism, metabolites, excretion potency, selectivity of receptors, and toxicity. So DAPA happens to be a chiral molecule with 5 stereogenic centers, and the right stereogenic center is the key for its bioavailability, rate of metabolism, metabolites, excretion potency, etc. And that might not be the case when you do not have that exact stereogenic center with the generic dapagliflozin. So that might be flawed completely. So can cardiorenal benefits with originated DAPA be extrapolated to the generic DAPA? Again, a big concern. We know we have all the cardiorenal data with the originator molecule. However, I do not think it can be extrapolated to the generic DAPA unless they are doing their own dedicated cardiovascular outcome trial or renal outcome trial. So with this thought, I want to end. All that glitters is not gold. So thank you.
Thank you, sir, for the wonderful talk. I would like to invite Dr. Sanjeev Pathak for his presentation. Dr. Pathak is a senior dietitian from Ahmedabad. He is only postgraduate reading in dietetics from Oxford, Victoria University, dietetics subject. He is principal investigator in more than 30 global clinical trials, including the new CVT trials, recipient of multiple awards, scholarships, and lectureships. Several publications, his first author and co-author in the leading journals of diabetes throughout the world. He is a life member of various associations, ex-president of Association of Physicians in Ahmedabad, director of Diurnal Variations in Ahmedabad, and he is the first diabetologist to start insulin pump therapy in India. And he has developed and published unique diabetes motivational health report, the Blue Index. These works are Dr. Pathak. Good afternoon and thank you for your kind words. I must thank Dr. Bansi Sabu, Dr. Manoj Chawla, Dr. Arvind, and the full organizing team of Diabetes India for giving me this opportunity. I will be talking about diabetes with cardiovascular and coronary artery disease, managing early by the 2008. And in continuation with what Dr. Tripathi and Dr. Mangesh Srivastava, that early control and control with the agents that just do not control glucose but also have other effects, especially the cardiovascular effects, is the way forward to diabetes management. And that is why SGLT2 inhibitors, GLP-1, all these have become the preferred drug in the management of that. I will be taking over from the glucose control to some other things which are also equally probably more important in the management of type 2 diabetes, especially for preventing or for managing the cardiovascular disease. Scenario is not uncommon in our practice. The young gentleman, even if he is uncontrolled, his BMI is not that high, his lipids are abnormal, he has been given anti-diabetic therapy but has never been treated for his lipid abnormality or for the other things which need to be. Let us discuss about this. We know that cardiovascular disease is the leading cause of death in India, and
And this is true as far as the lipid levels are also concerned, that at any level of LDL, the risk of a diabetic person developing cardiovascular disease is much higher. The pointer is not working? The risk of developing cardiovascular disease is much higher. So you can see here that in a diabetic person, even the LDL of less than 80 is responsive for a significantly higher number of cardiovascular events. So appropriate management is required for both, for coronary artery disease as well as for preventing coronary artery disease by treating dyslipidemia. And the Indian phenotype needs to address both the cardiovascular disease as well as dyslipidemia. Now let us talk about the sympathetic overactivity that exists in our population, especially the diabetic population. Stress, we very well know that it affects Indians to more extent than the Caucasians. 9 out of 10 of our people are having some form of stress. And 1 out of 2 Indians feel that they do not feel sufficient time for social activities because they have to work so hard to meet the ends. And in that process, they do not allot sufficient time for their hobbies, they do not allot sufficient time to the family. Moreover, in this COVID pandemic, this stress has increased significantly. Amongst the hypertensive people in India, about 62% of the people are having increased sympathetic activity. And stress, diabetes, smoking, obesity, all this adds to this sympathetic overdrive. And this sympathetic overdrive is associated with not only increased heart rate, but also multiple cardiovascular risk factors. And that accounts for hypertension, insulin resistance, obesity, subsequently the coronary events, even sudden cardiac death. The increased heart rate, on the other hand, caused by the sympathetic overdrive, will lead to arterial wall stress, endothelial dysfunction, atherosclerotic plaque formation as well as rupture, leading to events, sudden death, or even heart failure. So sympathetic overdrive definitely exists and is responsible for the cardiovascular event. In diabetic people, this sympathetic overdrive is even more because of the insulin resistance, inflammation, more norepinephrine release, and all this again increase the sympathetic drive. Compared to the person who does not have hypertension or diabetes, a person with diabetes has more sympathetic overactivity. A person with hypertension is also having more sympathetic overdrive, and a person who is having both hypertension and diabetes is having significantly increased sympathetic activity. What are the symptoms of sympathetic overactivity? Well, tremors, restlessness, inappropriate sweating. And one interesting symptom which is mentioned here is fast speech. And that you must have experienced in your busy clinic hours when there is significant amount of people waiting in your waiting room. Then your speech becomes fast and loud, and that is one of the interesting signs of sympathetic overactivity. Moreover, from cardiac perspective, it is reflected as in elevated heart rate. And you can see here that elevated heart rate more than 100 is associated with a robust increase in the cardiovascular events rate compared to the heart rate of less than 60 or 70. In this slide also you can see that the beautiful study also showed that heart rate of more than 70 versus heart rate of less than 70, there was 34% increase in the risk of cardiovascular death, 53% increase in the heart failure, 46% increase in the myocardial infarction, and 38% increase in the coronary revascularization, which means that the elevated heart rate, even more than 70, is significant enough to increase the cardiovascular risk. We know that the first and the second line drugs which are recommended for diabetic patients with hypertension are ARBs, or in addition to that either a diuretic or a CCB. Having said that, in a patient with increased sympathetic activity, there are sufficient evidences, more so in patients with angina, post-MI, heart failure, and people with elevated heart rate, that even beta blockers can be considered along with the other drugs, because beta blockers can be combined with any of the drugs which I already mentioned. And this is label 1A indication. How do beta blockers help? they reduce the sympathetic stimulation, they reduce the heart rate and cardiac contractility, and they reduce the myocardial oxygen demand. All of you do not need any further education regarding the beta blockers' utility in patients with cardiac disease. That is very, very well evidence-based. Amongst the beta blockers, it is the metoprolol which is tried most, and in this study, which is long back done, it showed that it reduces the all-cause death by about 22% compared to the diuretic therapy, and the sudden cardiac death by about 30%. Among all the metoprolol preparations available, choosing the beta metoprolol with the MUPS-ZOC, that is multiple unit pellet system technology, giving zero order kinetic, gives the desired constant plasma concentration for 24 hours compared to the generic metoprolols, because in most of the generic or the gel matrix system developed metoprolol, the drug gets released in about 10 hours. More than 90% of the drug gets released in 10 hours, and so the efficacy does not last for full 24 hours compared to the MUPS-ZOC technology where the efficacy lasts for 24 hours. The key benefits of this type of metoprolol is that you can truly give it once a day, and so the compliance will be better. The therapeutic plasma concentration is smooth and uniform for 24 hours. There is higher beta-1 selectivity, and that's why less side effects, higher degree of response amongst the hypertensive patients, and the ethyl cellular polymer outer membrane prevents the impact from the physiological factors so that their absorption is not affected by food intake, pH of body fluids, and other co-administered drugs. And that is why this type of technology is preferred as far as the metoprolol is concerned. Coming to the dyslipidemia management in our diabetic patients, we very well know again that diabetic people are at risk of cardiovascular disease even before the clinical onset of diabetes. And that is why the therapy should be started as early as possible rather than once the plaque has already developed, and once it ruptures, it leads to a sudden cardiovascular event. It is not only the level of cholesterol which is important, but the duration of the exposure to LDL or cholesterol is also very, very important. The lower the age a person gets exposed to the cholesterol, higher is the risk. And that is why the therapy for the lipid lowering should be started as early as possible. This is a very good representation in two models. The model A, that is the benefit that is achieved by lowering the lipids once the plaque has already developed. At that point of time, it will just prevent the plaque rupture, or it will do the stabilization of plaque. Whereas the model B shows that you give the statin therapy even before the plaque has developed. And you can see the results of this study. The 30-year risk, you can see here that in the model A, when the statins were given after the plaque had developed, the risk avoided was 20.8%. Whereas in the model B, it is about 44%. That means the early initiation of statin therapy in a person who is at high risk of developing cardiovascular disease, as for example, any diabetic person, is definitely having significant evidence. How do we determine that this person is already having a plaque? I think at present, coronary artery calcium scoring is one of the best markers. Very economical, relatively non-invasive, requires very few amount of radiation, and that should be, I think, advised to most of the diabetic patients at least once in 2 or 3 years. If the score is 0 and if the lipid levels are normal, you can still wait for the lipid lowering therapy. But once plaque has started developing, you should not delay the therapy. We know that the score more than 1000 is associated with very high risk of a cardiovascular event, but even score of more than 100 is also associated with significant number of people developing coronary artery disease. Lipid lowering therapy itself is responsible for most of the cardiovascular preventive strategy that you can do for your diabetic patients. The STENO2 study and the UKPDS risk engine developed from the UKPDS study and the STENO2 clearly showed that in a diabetic patient, about 70% of the benefit of the cardiovascular risk reduction can be achieved just by giving the appropriate dose of a statin. Well, this is pre-SGLT2 era. Now after the SGLT2 era, probably SGLT2 inhibitors also have a significant role to play in preventing a cardiovascular event, but that is mainly for the heart failure and not for the atherosclerotic cardiovascular event. From atherosclerotic cardiovascular events, still I think statins are the best drugs to prevent that. Just 1 millimole, that is 38.7 milligram of reduction of LDL will result in 24% reduction in the major coronary events, 24% reduction in the coronary revascularization, 15% reduction even in the stroke, and the vascular death, any death, major vascular events, they all are significantly reduced just by a reduction of 38 milligram deciliter lowering of LDL. What do the guidelines recommend as far as the lipid lowering is concerned? Both European Society of Cardiology and American College of Cardiology, the guidelines are that the LDL should be primary target. For our Indians, it is not just LDL, but also non-HDL, which is equally important. Lower the LDL, better it is. And both the guidelines emphasize for 50% lowering of LDL and also ask for the specific value of LDL reduction for further clinical action. In a diabetic person, regardless the patient is having lipid abnormality or not, regardless the patient is having coronary artery disease or not, they deserve a statin therapy. If they are having already a cardiovascular event, it has to be an intensive, that is high intensity statin therapy. Otherwise, you can go for either SCORE or ASCVD or QRISK, whatever is appropriate for our patients. In our clinical settings, I think it is the QRISK or JBS, which is more representative of cardiovascular risk, but correct me if I'm wrong. Dr. A.K. Singh is here now, so we'll have his comments too. We need to set the goal of 50% LDL reduction minimum, because you can see that compared to non-statin therapy, 50% reduction in the LDL is associated with 57% reduction in the event rate. Moreover, compared to just 20% reduction, which you can achieve with maybe 5 milligram Rozua or 10 milligram of Atorva, 50% reduction, you can see a significant difference. The number needed to treat changes from 63 to 26 once you achieve 50% reduction in the LDL. Now, amongst the statin, right now we know that we are all bombarded with the non-statin therapies like bempedoic acid. It's a good drug, no doubt, but at present it does not have a cardiovascular evidence till the clear outcomes are out. So at present, obviously, statin remains the gold standard. Amongst the statin, which one to choose? Well, I'll quote some of the studies. Uranus is a head-to-head comparison of atorvastatin versus rosuvastatin, and you can see that with rosuvastatin, the LDL lowering is much better. The LDL-HDL ratio is also much better, and the non-HDL, which is a co-primary target for our Indian patients, is also much better in the comparable dose. The number of patients who achieve the target is again better in the rosuvastatin group compared to the atorvastatin group. And in the Jupiter study, we know that even in the non-diabetic or IFG patient, the reduction of the cardiovascular event was very, very significant. 31% reduction in people with impaired fasting glucose, 49% reduction in people with normal fasting glucose. The Voyager analysis, it's a meta-analysis of different statins, Rozua, Atorva, Simva, and it also showed that rosuvastatin, even at 5 milligram, is as effective as 10 milligram or 20 milligram of atorvastatin and 20 to 40 milligram of simvastatin. Rosuvastatin 20 is as effective as 80 milligram of atorvastatin. So rosuvastatin is definitely much more potent compared to any other statins. And this is again a comparison done in Uranus, Andromeda, and Coral study, where again it has been shown that rosuvastatin has better efficacy in reducing the LDL as well as non-HDL, both in diabetic as well as non-diabetic patients. Moreover, the evidence of reversal of atherosclerosis is only there with rosuvastatin in the asteroid study it showed 78% plaque regression compared to non-rosuvastatin therapy. Again, amongst the rosuvastatin, why choose the innovator or the research agent? Two reasons. One is that the purity is responsible for the expected efficacy, and the impurity that is there in many of the generic rosuvastatins is responsible not only for less efficacy but also to its increased side effects. We very well know the presence of methylated impurity in generics, especially atorvastatin, subsequently losartan, valsartan, and ranitidine. This NDMA or the methylated impurities may be responsible for some of the side effects that are associated with these drugs. These impurities also affect the efficacy and stability, especially for the rosuvastatin. Stability is also affected because of the impurity. Is there any evidence that the generic statins will have more risk? This study done in Spain showed that compared to the innovator statins, the probability of suffering a cardiovascular event for generics was higher by an average of 31%. So it is better to use the innovator statins. Finally, to end, we know sympathetic overactivity is much more common in our Indian people, and it is elevated more so in diabetic people, obese persons, smokers, and due to stress. Elevated heart rate increases the risk of cardiovascular event and risk of cardiovascular mortality in patients who are young especially. Metoprolol is the drug which reduces the sympathetic overactivity, and it reduces the heart rate, it reduces the sudden cardiac death as well as all-cause mortality. Amongst the metoprolol preparations, preparations with MUPS-ZOG should be preferred one. Talking about the dyslipidemia, we know that LDL and non-HDL are the primary and co-primary targets for our Indian population. We Indians develop cardiovascular disease even at a lower LDL compared to the Westerners. Statins still remain the first line and the gold standard as far as the cardiovascular risk reduction and the lipid lowering is concerned. Among different statins available, rosuvastatin has highest number of evidences both in diabetic and non-diabetic people. Rosuvastatin help LDL reduction by about 52%, triglyceride by 21% in diabetic dyslipidemia, and compared to the innovator statins, the probability of suffering a cardiovascular event is higher for the generics by an average of about 31%. Thank you very much for your very kind audience. Thanks again.
Thank you, sir, for the session. Any questions?
This is a very difficult question to address. But we can give an example that if you go for outside eating, what do you prefer? Eating in a lorry or eating in a restaurant? Or when you buy a water bottle, what do you prefer? So, pani ka khola or pani ki achhi bottle? Of course, having said that, in some patients, you have to consider the economy, and there you may have to prescribe the cheapest available brand. But in drugs like statin, drugs like SGLT2 inhibitors, in certain important drugs which will have influence on life and death, obviously, as far as possible, choose the order. Yes, sir, Dr. H.S. Singh is there, so we can have his expert answer of the practical factor. This is a very difficult question to answer. Are you convinced that diabetes is different?
You have to originate. You have to originate. Right? As long as it is working for you, that's fine. If something goes wrong, nobody is going to take responsibility. Unfortunately, this question is often asked by people who come in Mercedes and BMWs, and not by people who come from the small person. What if I already told you that is what? As long as you are working with government setup, writing generic there, you're fine. Somebody comes and challenges you, is there to do it. If it is your private practice, somebody is there comes and sues you, you have to pay the price. Nobody is going to fight that case for you. Government is not going to come back and save you. If you are working with work which is government able, if somebody puts a case on you, is the government going to come and save you? Yes or no? Is the government going to come and back you up? No. Your lawyer is going to do that for you. Only question I ask, are you convinced with the data that you have, or the data is different from? Okay, sorry to interrupt. Yeah, is earning. Hello. The point you, if you prescribe a generic product, you will be sued, is incorrect. What? Think about which point are you mentioning to highlight? I was saying that once you say that if you do take wrong, you will be sued. That's not correct. Gentleman was saying that all of us people see, we should not know everything. Okay? Have one high quality. The same time, not have questioning. But him, totally agree with you. So the point is, not all generics are as good as the originator. At the same time, I personally believe if it is your personal practice and somebody comes and challenges you, you will have to answer for that. So are you going? No, no. So it's your choice. Nobody is going to tell you what to do. Sir, the point is nobody is going to tell you what to do. It is your practice, it is your choice. If you want to stick to generics, as long as it is working for you, that's fine. If it doesn't work for you, then it's okay. Excuse me. Unfortunately, this will never end. This is a debate that we are going to have. Can we take it outside during the coffee? Because I think Dr. A.K. Singh is here to start his next session. Debate will go on. We declare the session over. And I think the name of the game is the customization. We have to customize the statement according to the patient, according to everything. Thank you very much for all the speakers, and we invite the chairperson for the next session. We are welcoming two chairpersons, Dr. Gupta and Dr. Sonali Gupta.